everyone, and welcome back to another episode of the Core Console RX podcast. My name is Mike Corvino. With me, as always, Cole Swanson. Cole, what's up, man?
Doing great. And we got a third one in the studio today, too. My beautiful fiance, Anna. She didn't want to be on because she's a little shy, but we'll probably get her on here at some point.
Yes.
Yes.
And Anna is about to be a PA.
Yeah. She's got one more rotation left and graduate in late July. So very proud. Very proud.
Yes. And we'll get her on the podcast very soon.
Yeah. Now, on a more significant note, I'm also a little less of a man than I was last time we recorded, unfortunately.
For those of you who are watching live on Instagram or on YouTube or whatever afterward, Cole has no beard anymore.
I don't.
So we really thought about actually asking him to no longer co-host the podcast because of the lack of beard.
It was almost a deal breaker.
Yeah.
I at least would have had to put on one of those, strap-on beards like they get from the party store. Mm-hmm. At the least.
We're actually still keeping that in our back pocket.
Right. Next time.
We're going to see how this goes.
It was forced on me. It was not by choice.
Yeah.
It was not by choice.
His employer has not realized that beards are a necessity for healthcare.
Hopefully they will soon. I think they will soon.
Yeah. Just takes a while to convert.
I know. Only like 8 years.
But, and the thing is about beards, since we're on the subject, I feel like you're able to consult your patients a lot better with a beard.
Yeah. Well, they respect you more.
Yeah.
Think you're a little wiser.
Number to treat is like 6.
It's evidence-based.
Uh-huh. I don't know the trial. I can't remember the name.
I mean, the superiority is proven thousands of
time and
ago.
time again.
Time and time again. I mean, not having it is really giving me some anxiety.
Yeah, I can imagine. Yeah. And what's weird about that is that's like kind of a segue.
Oh, is it?
Into what we're talking about today.
Wow. Crazy.
Yep.
Look at that.
Anxiety.
Yes.
So we've talked about depression in earlier podcasts, and I talked about STAR-D. So some of the drugs that we're going to talk about are going to be the same, but
yeah, there'll be a little bit of overlap. But they're good drugs and they're used for multiple purposes. So we'll be focusing in on generalized anxiety disorder. And there are other anxiety disorders, but we're going to focus on that. So
we will we're going to start off kind of going through a patient case.
Yeah. And
then from there, we will work our way through all the different options, talk about some of the side effects, things we would have to watch out for, and kind of see if we can help this guy out.
Yeah. We'll use the case to frame kind of our recommendations and how we walk you through treating GAD.
All right, so the case, and we can put a copy of this online.
Sure.
But the case, KR, is a 59-year-old male that arrives at the clinic today to discuss options to treat his anxiety. He experienced a STEMI 5 months ago and underwent PCI with drug-eluting stents. He has suffered from mild anxiety for many years, but the condition has been much worse since his MI. He claims that he often feels fatigued during the day due to an inability to sleep at night. He says that he worries about having another MI, and those thoughts keep him awake most nights. So he has been self-medicating with ZzzQuil, also known as diphenhydramine or Benadryl. Mm-hmm. The marketers did a heck of a job on that one.
Yeah, throw 3 Z's in there and they'll use it for sleep.
Uh-huh. And so his current med list, he's got clopidogrel 75 milligrams, aspirin 81 milligrams, atorvastatin 80 milligrams, lisinopril 30, amlodipine 10, and then diphenhydramine 25. So given his current med list, we're going to try to figure out what the best options are going to be for him.
Mm-hmm. Do we treat? Do we not treat? Do we actually start a medication? Is it something PRN? Is it every day? We'll look and we'll see what would be best.
All right. What do you want to start off with?
Well, that guy's doctors probably could have listened to our last podcast and benefited a lot.
Yeah.
He seems to have a lot of issues like angina and STEMI that we talked about.
The last podcast, which was killer, if I do say so myself.
It's doing well, too.
It is, yeah. It's actually one of our highest downloaded podcasts.
Yeah, it's a good one, so check it out, angina and STEMI. Anyways, we can just start out with what generalized anxiety disorder is in general, because as we know, everybody seems to have anxiety, whether it's transient or long-term, happens to anybody. GAD's characterized by a period of time where you're having persistent worrying, hard to control, that's causing significant distress or impairment, and it occurs on more days than not for about 6 months. That's how they classify GAD. And it's pretty prevalent. If you look at studies in the United States at least, throughout your lifetime, you will have that diagnosis between 5.1 and 12% of people will. That's in the U.S. In the U.K., it's more like 4.3 to 5.9. So apparently we're a lot more anxious over here. But that's, 10% of people are going to have those types of symptoms for that period of time. Whether they're treated or not, who knows? But they'll have it. And it's often associated with other comorbidities like social phobias, other types of phobias, or even panic disorder, which a lot of these medications they'll see benefit from them for those things as well.
So, in regards to the treatment options, obviously there's a lot of variables. Like Cole was saying, comorbidities is huge, and kind of figuring out what best for each patient based on their comorbidities. First line, typically, if we can, is going to be our SSRIs.
Right.
So
similar to depression.
Exactly. So just like in depression, working on the serotonin neurotransmitter first is usually beneficial for patients. They're not real high on side effects depending on which medication you're using in that class. They're relatively cheap, and we can really kind of figure out which ones are going to interact with certain drugs and things like that.
Yeah. So, I always mention this, but sexual dysfunction is a considerable side effect that should be mentioned to people. I don't know why I always bring that up. Yeah, it's important.
First,
they don't realize
too.
It. Yeah.
We didn't even get into the
We're
drug
not
class.
even into them yet, but you just got to know it's there. No, they're going to stop taking it.
Yeah, it's true.
They're going to stop taking it.
That is true. So, SSRIs, for this particular patient, if we were going to start the patient on one, there's a lot of different options, obviously. There's citalopram, there's escitalopram, we have fluoxetine, we have paroxetine, we have sertraline, et cetera, and et cetera.
Mm-hmm. All good drugs, except for paroxetine.
Except for paroxetine. That one's terrible. So, the big question is, obviously, like I said, looking at comorbidities. So this particular patient, he's had a STEMI, no history of arrhythmias necessarily or anything like that, but since he's had issues with the heart, if he's on other drugs, especially that could potentially prolong his QTC interval, then we would probably want to avoid things like citalopram. Escitalopram also has that risk. It's probably not huge as far as risks go for QT prolongation, but it's something to definitely consider.
Right, because obviously QT prolongation isn't going to cause an MI, but it's just that he has a cardiac history, so probably not the best first-line option for him.
Now, like you said, paroxetine, that has been compared directly to escitalopram and was shown to be not as effective.
Mm-hmm.
And so in that case, paroxetine's out. Plus, paroxetine is the shortest acting SSRI, so it's the hardest to come off of. Mm-hmm. It's got the most drug-drug interactions. There's some evidence that it may not even be that effective in general, period.
Mm-hmm. Worst sexual dysfunction, it's pregnancy category D as opposed to the rest, which are category C. Yeah.
A lot of issues with paroxetine.
Yeah.
And so it's not my favorite.
You mentioned the short half-life, so I think we talked about it in depression, but that's going to create a worse discontinuation syndrome. So if you're ever taking patients off of these medications, you want to make sure to taper them off slowly. Paroxetine, if they stop it for a few days, they're probably going to see significant symptoms of discontinuation syndrome, which are similar to most withdrawal symptoms from any drug that's going to have some type of physiological dependence effect. And then fluoxetine has the longest half-life, so it's going to be the best about discontinuation syndrome. Won't be as significant.
All right. So sertraline is the other option that we haven't talked about.
Mm-hmm.
Now, there's actually a study called SAD Heart where they looked at the use of sertraline. In this case, they were looking at major depression, but it was in patients who had had acute MI or unstable angina, so some kind of ACS event. And what they found was that there didn't increase your chances of having a cardiovascular event. And so, the patients kind of fit this guy's profile other than treating depression versus anxiety. And so I think sertraline in this guy's case would be probably the best option. Now, the other thing to consider would be drug-drug interactions. Because he's on clopidogrel, if we did use sertraline, then clopidogrel is a prodrug, so it has to be metabolized in order for it to be activated. And so we would want to watch out for drugs like that. Really, the only one I'm thinking of in this SSRI class is fluoxetine.
Mm-hmm.
So I think we're good on that one because the first one I would look at is clopidogrel. That's going to be his most important. So fluoxetine probably wouldn't be a good option in this guy. Sertraline's not going to bother that enzyme, so I think he's fine on that one. And then other than that, I mean, really no other drug-drug interactions that we would be all that worried about.
Right. So that's for if you wanted an SSRI, sertraline would be pretty reasonable in this guy. If you could cut that one out for some reason, if there's a reason you couldn't use sertraline, you can move on to an SNRI, which are also very reasonable options. Effexor is probably the most common one, but Cymbalta, duloxetine can also be used, and both have been shown effective in GAD.
Absolutely. One other thing I want to throw in there too, because if let's say we start him on sertraline and then we run a drug-drug interaction check against his medications, one of the things you'll see if you're using like Lexicomp, for instance, it should categorize it as about a C interaction, but it'll say for platelet, it'll decrease platelet aggregation. So one of the ways that happens, and we would be worried about that because he's already on clopidogrel and aspirin, so we'd be worried about bleed risk. The reason for that is because basically platelets have these particles. They have various chemicals inside these particles, some calcium, adenosine diphosphate, serotonin being one of them, and then other, like their alpha granule has like von Willebrand factor and all that. But the serotonin component is actually taken into the platelet via a channel that they pull in from the surrounding area. They can't actually create serotonin. And so the SSRIs will actually block the uptake of the platelets are able to bring in serotonin, so they can't store it. So they're not able to release that to other platelets to begin that platelet aggregation. And so the platelets basically thin out that way because they're not able to start the clotting process.
So in a patient who is already on dual antiplatelet therapy, they're going to have an increased risk for bleeding, which, it's not going to preclude you from using one of these medications, but definitely something you want to be aware of as you're monitoring him long-term for GI bleeds, lower and upper, and really any other type of bleed.
Yeah. And probably not a huge clinical...
Not really.
Probably seen, but...
Like, it'll like, if we're pharmacists, so we would see a pop-up.
Right.
Our computer would catch it, and we'd say, okay, be aware of that, but, we're moving on.
Yeah, like you said, I probably wouldn't be worried about this unless they had a history of bleed.
Right. A history of bleed is really the only way you'd be worried about that.
So just wanted to throw that out there, though, in case any of you see that interaction. That's why it happens, because it's kind of weird when you first see that one.
Yeah. And I also meant to mention, so SSRIs are definitely a reasonable first-line option, but as with any psychiatric illness, cognitive behavioral therapy is always a good option to either be used alone or in combination with medications. So definitely consider that. I recognize the patients tend to have trouble following up on CBT therapy, but still, it's worth giving it a try. It definitely works. They've even have trials looking at CBT over the phone. So if the patient just is not adherent to coming into the office and or following up with a psychiatric provider and doing the CBTs, they could look into calling them and do it over the phone, and it can either augment medications or they could try that, alone for a few months before considering putting them on a medication for, we'll talk about it, but, up to a year or more.
Yep. So the other issue with SSRIs, obviously side effects, we started off talking about sexual dysfunction, but we'd also have to worry about GI issues potentially.
Especially at the beginning.
Maybe some weight gain, orthostatic hypotension. He's already on blood pressure meds, so...
I think an important thing to mention to these patients especially is that it can actually increase your anxiety at first, in the first week or two, but it's transient. And so over time, obviously, it helps, but just the effect that it has on serotonin overall can actually increase your anxiety in the beginning, which would, if they weren't aware, would definitely make them discontinue it if what they're going in to be treated for is now getting worse from taking the medication. Plus they're having diarrhea, so everything's bad.
Diarrhea makes
and
everything
sexual
worse.
dysfunction. Oh my goodness.
Yeah.
So just warn them.
Yep. So, all right, you started talking about SNRIs.
Yes.
Take it away.
So the only difference, obviously, instead of just acting on serotonin, they're going to be acting on norepinephrine. We went into that a lot during the depression podcast. These medications are used for various things, including certain types of pain. But Effexor is usually my go-to, which is venlafaxine. But duloxetine, which is Cymbalta, can also be used as well.
Yep. And then desvenlafaxine, probably not any better than venlafaxine, but it is generic now.
Yeah, it's
so
generic.
if you want to get that
still
one
a little
shot,
more
you
expensive,
could.
but people,
probably
people do use it. Yeah, I see it.
So was it Prestique brand name?
Prestique. Why do they? Is it supposed to have less side effects?
I think too. It's the and I may butcher this. This is totally just me guessing, but I think it's just because it's like the right-handed enantiomer, and so it's supposed to bind a little bit better to those reuptake inhibitors.
A little more potent.
Yeah. Presynaptic neurons or all that jazz.
All that jazz.
Just say it right and don't mess up the words, and people think you're right. It's been my go-to. All right, so we've tried SSRIs, SNRIs possibly. If those two don't work, what are we doing now?
So there's some other options that have shown benefit in GAD. I think one very reasonable option is Buspar, which is buspirone. It's very mild. It doesn't work for everybody, but for some people, that's all they need, and it works very well. It ultimately, notice that we haven't talked about benzos yet. So we'll get to benzos at the end because that ultimately should not be the first go-to for GAD because of their addictive potential, their interactions with opioids and alcohol and all that sort of stuff, their sedative properties. But Buspar isn't particularly sedative. It's not addictive, and it can help with anxiety, but not in everybody. But it's definitely a good alternative to benzos if that's what you're considering. It does act on serotonin. It blocks the 5-HT1A receptors, which is a little bit different than the 5-HT3 receptors, which the SSRIs act on, but it does act on serotonin as well.
And buspirone was also one of the drugs that was used in depression for the STAR-D trial that worked well.
Yeah, it was, wasn't it?
Mm-hmm. So definitely a good drug. I think it's one that we don't think about as often.
Right. Because it is not, I won't say wimpy, but it's I would say it's not as effective as an SSRI or SNRI, but very limited side effects. That's what I like about it.
Yeah, don't be picking on buspirone.
I know.
Okay.
I'm not. I like
it's
it.
2018.
You can't discriminate.
Can't discriminate against buspirone. All right. Where are we at now? So what about pregabalin? Lyrica.
Yeah, they looked at that.
So I guess it has some efficacy when it comes to anxiety disorder, but that's compared to placebo. I don't know that it's been actually compared to anything else. I know it's better tolerated a lot of times than some of the benzos, things like that.
Mm-hmm. But it is a controlled substance.
It is a controlled substance.
I should say in our state. I assume nationwide, but I don't really know.
I think so.
I think so. I think it's a C5 everywhere.
Gabapentin's starting to go control in some states too now, which is the cousin of pregabalin.
So gabapentin, it's not indicated for anxiety. Interestingly, gabapentin is only indicated for post-herpetic neuralgia. But look at all the stuff that it's used for, and it's very frequently used for anxiety, especially if somebody's like, well, this person could be on a benzo, so alternatively, I'll just put them on some gabapentin. Yeah, not really ideal. Let's look into something potentially different. But pregabalin does have some data, whereas gabapentin doesn't particularly.
And just as a side note, in case you're thinking pregabalin, gabapentin, that's right, remember, it works on GABA. Mm-hmm. It does not work on GABA. Common misconception. It works.
So where does it work, Mike?
The alpha-2 delta subunit of the L-tape calcium channel. So it's basically just decreasing your excitatory neurotransmitters, substance P, glutamate, things like that.
Yep.
So it can upregulate some of the GABA downwards, but it's not going to actually work on GABA directly.
Right.
But yeah, not approved for GAD, but an option possibly.
Right. And it does have some side effects. So it'll have most similar side effects to most CNS acting medications like sedation and dizziness. You can also become tolerant to it, and because it's controlled, withdrawal and dependence are possible. And I think it can have some peripheral edema, kind of like gabapentin, right?
I'm not remembering off the top, but maybe.
I know gabapentin can, so I would think Lyrica can as well. But
yeah, probably.
Actually, I talked to a patient 3 weeks ago who was on pregabalin originally, had some really bad swelling in her legs, and they actually switched to gabapentin, and she was okay. So that's interesting. Yeah.
Just thinking pregabalin.
I know. Come on,
pregabalin.
Come on.
All right. Benzos.
Yes.
Let's talk about them.
Dum dum dum.
So now again, when we're talking about disorders like this, we're coming about it from a non-specialized point of view. Neither one of us are psych experts. So if you're at home and you are a psych expert and you're screaming at us right now going, sometimes it's appropriate to use benzos first line. Relax, we got you. And we agree. I'm sure there's definitely scenarios where we should use them. We're talking generally speaking.
We're talking generally.
And we don't obviously we don't paint ourselves as experts in this field. So a true psych expert can definitely figure out, I'm sure, very quickly whether or not a patient does truly need to be on a benzo.
Right. And we're talking generally because generally I think that people will consider benzos as a first line medication, which they obviously works for anxiety. It's just the side effect profile that we're concerned about.
Yeah, and especially if the patient's going to a primary care provider who is treating their anxiety, not a psych specialist.
Right.
So, all right, benzos. Where do you want to start?
I mean, we've hit on benzos on a lot of podcasts, so you guys know that they are potentially addictive, or they are definitely addictive. There are concerns using them with opioids. There was a big meta-analysis that came out showing an increased risk of death using anxieties along with opioids, and especially when there's alcohol involved. So like I know the VA is like absolutely a no-no to have people on benzos and opioids at the same time. Like if you are, then they're gonna take it off. They're gonna start a taper. They're gonna get you off of one of them, and that's just the way it is. But still, there are a lot of patients who are on both. You just want to be careful.
Mm-hmm. Absolutely. Contrary to popular belief, the alcohol is not there as a primer,
right,
to get the benzo started.
Get the benzos working better.
Yes, we
not how it works.
Not do that. There is comparative potencies for them if you're trying to kind of figure out doses or conversions between benzos. I put something on Instagram today actually for conversion rates of benzos, so it's a little bit easier to switch back and forth. Not that you're switching benzos all the time, but just in case. And then, they also have to deal with how long the drug will last in the system. Mm-hmm. The half-life varies very significantly for benzos.
Yeah, so very frequently what people will do is put a patient on an SSRI, and we actually talked about how a lot of times anxiety can be increased in the first couple of weeks. And I don't think we even mentioned that similar to depression, it's going to take a while for the symptoms, for them to see really good symptom benefit, up to, a month to 2 months. So frequently people will give a benzo in the interim before the SSRI really kicks in to help with that. And I don't know. I kind of have mixed feelings about it. It definitely makes sense. It just seems like a lot of time patients are like, well, I don't really think this SSRI is working for me, but this benzo is great. And now that you've started it, I want this benzo. And then you kind of have to deal with that situation. So just kind of play it by ear, I guess.
Yeah, I think that's the big thing, is just making sure it actually comes off. If you're going to use it to get onto the SSRI, making sure that it actually is removed at some point. And
they don't use it like daily scheduled like an SSRI. It's here's some Ativan or here's some Xanax. Use it PRN when you're like having really bad anxiety, not just as you go throughout your day.
Yeah. Well, and I will say too, though, if you're dealing with more, not just general anxiety, but if you have a patient that's experiencing like true like panic attacks, I've seen where they'll prescribe PRN benzos for if a person's experiencing a panic attack, then they tell them to take the benzo. The problem with that method is by the time the benzo actually starts working, the panic attack is most likely going to be over.
Yeah, even if they start taking it right when the panic attack
begins.
And that's if it's a true panic attack. Like people can be in constant states of pretty significant anxiety, but that is a little bit different than having an episode of a panic attack.
Yep, exactly. So I think that in that case, if it's a true panic attack, like you would need to actually schedule the alprazolam or Klonopin or whatever you were going to use.
Right. And so unlike pregabalin and gabapentin, benzos do act directly on GABA receptors, right? They basically mimic alcohol in the brain. They act the exact same way, which is why people will frequently use benzos for alcohol withdrawal symptoms. But that's another reason why you wouldn't want to use both of them together, because you're going to have additive effects of sedation.
Yeah. And, obviously you're increasing risk of side effects, falls, things like that when you have an elderly patient.
Mm-hmm.
This guy's not really elderly, but he's
And how old is old KR?
59.
59.
So not elderly, but not super young either. So kind of something you'd want to at least be aware of. Use some caution. And then again, like we keep saying, making sure we're actually getting it off at some point.
Yep.
Let's see. We can also.
So I think that's the big ones, right?
Yeah, those are the main ones. Other antidepressants, I guess the tricyclics, mostly thinking more along the lines of depression for those, but they are used in certain panic disorders.
They work, but lots of side effects. So we're definitely not considering those first line medications.
Yeah, anticholinergic side effects.
Yeah.
Especially in the elderly as well. We want to watch that. Make sure that.
I think more significant QT prolongation with those as well. So in our patient, definitely not the best option.
Yeah, definitely not. Mirtazapine.
So there's Remeron.
So that one, it can be also used in depression, can be very effective for some people. Lots of sedation, lots of weight gain.
Right.
Makes you super hungry.
Makes you hungry. So they'll use it sometimes in patients who they want to gain weight and also have depression. Even though fixing the depression might fix, their lack of eating, but they'll use that as well to promote appetite. And while it may work, it doesn't have a whole bunch of solid evidence, which is why it's not FDA approved for anxiety, and it's not really first line either.
Yeah. I was listening to a podcast, and one of the guys talking on it had experienced depression, was kind of talking about it, and was talking about being on mirtazapine. And he said that he would literally just run around his apartment trying to find more stuff to make so that he could eat.
Really?
He said he was a really skinny guy at the time, and he would just run around and just be like, "What else can I put together?" So he was hungry constantly. He said he was like a competitive eater.
That's hilarious.
Yeah.
So give that one at night as well, because it's gonna
Make him tired.
It's gonna make you tired. So there's also antipsychotics that work for anxiety. So Seroquel is a very common anxiety medication. It's a very common antipsychotic medication. So like we said, there's a lot of comorbidities associated with anxiety. So if they also have comorbid bipolar or comorbid, bipolar favoring depression with anxiety, then Seroquel may be potentially a good option to kill two birds
with one stone.
With one.
As they say.
Yes. Unless you're taking two pills, then I guess it's
multiple stones.
Multiple stones.
The other option that you'll see out there is hydroxyzine.
Atarax.
So, yes, it can be effective. There's a meta-analysis that compared five trials, but it was still fairly small. It appeared to be a little bit effective. However, lots of fatigue and sedation with hydroxyzine.
They even found that it has more sedation than benzos because it is highly anticholinergic. It's basically Benadryl that works for anxiety. And I think that the psych folks really like Atarax, and mainly because a lot of their patients are currently on benzos, have been on benzos. They're trying to get them off of benzos and have potentially some addiction issues. And so for them, Atarax is a good alternative to benzos. That seems reasonable.
Yeah.
But you got to be aware that it's definitely going to be pretty sedating. It's not going to be as effective as benzos. So a lot of times you'll switch them to this stuff and they'll be like, what are these sugar pills that you've given me? This is nothing like my Ativan. So caution them that it's not going to be the same, but it doesn't have the addictive potential that benzos have.
Yeah.
That's the benefit.
Or just write Ativan on the bottle.
Right.
You could do that.
They used to do stuff like that.
Yeah, you were telling me about something like that, weren't
they
you?
could put whatever the pharmacist would have to put whatever the doctor said on the bottle, even if it was a different med. Like if it was a placebo, you'd have to say, "Oop, this is for pain."
What, wasn't it you that was telling me about that? Like
I think
would actually, the doctor would prescribe on the paper, like, say it's this, but give them a placebo.
Yeah, and don't cite me on that because it was an older pharmacist who told me that. So who knows? She could have just been making the whole thing up.
I think it's a good story, and I'm believing it.
Yeah, it sounds like something that they would do back.
Yeah, 100%.
Back in the 50s or whenever it was. So
way back then.
If anybody knows, let us know.
We'll have to ask Dr. Wirt about that one. I bet you he knows.
He'll know. Oh yeah.
If nothing else, just for the history aspect, I'm pretty sure he knows about that.
Sure, absolutely.
That would be pretty funny. What's the? This is fun fact time. Hydroxyzine is the when we think about our second generation antihistamines, cetirizine is one of the active metabolites of hydroxyzine.
Interesting.
That's why cetirizine is considered to be the most sedating, non-sedating antihistamines.
Which is why they came out with Xyzal, which some consider third generation antihistamine. It's levocetirizine and supposed to be the least sedating of the antihistamines. I don't know. I haven't tried it, so.
They like their enantiomers, don't they?
They do. They're all about those.
Stinking organic chemists.
Those ants. Those ants.
So, yeah, the hydroxyzine definitely one I can't imagine trying to stay awake and function.
I would be completely knocked out.
Yeah,
like
immediately.
Benadryl, 30 minutes later, I'm done. Out for the count.
And then not only that, but when I am waking up the next morning trying to function like a human being, I feel like a zombie.
No, my mouth is all dry and I'm groggy. It's horrible.
Yeah, I'm terrible.
I'm glad I don't take meds because I don't think I'd react too well to them.
No, doesn't sound like it.
No.
What about duration of, like, how long are we going to treat this dude?
Yeah, so we didn't, I think I might have referenced it. So how long does KR, is it KR?
Mm-hmm.
How long does KR need to be on his anxiety medication? So similar to depression, similar to GERD, similar to a lot of disease states that start out acute and don't necessarily have to be chronic. You don't have to stay on medication forever if you start, if you're being treated for GAD. Granted, it does look like it needs to be for a considerable amount of time. So if we're starting him on sertraline, we're probably looking at least a year of therapy. There was one trial looking at Effexor. They did 6 months of therapy. It worked pretty well versus placebo. They saw a response rate of about 69%. Of note, placebo was like 40 to 45% response rate, which in all these trials, the placebo factor is like insane. Which makes me, I wonder if they'll ever go back to placebos being ethical again. Because in some cases, they really, no side effects, but they work. So who knows?
No side effects.
Right. No zero. It's sugar. Maybe, maybe weight gain.
What would be fun, what would be interesting is who would have a side effect to one,
right. Well,
and how many placebo companies would be getting sued for adverse events. Right. That would be the next question.
Well, I mean, there's the placebo side effects. You tell a patient they're going to have diarrhea, even if the medication's not causing it, they might just have diarrhea. Psychosomatic type thing.
Yeah.
Definitely happens.
You basically create the diarrhea in your own head.
Exactly. You are creating their diarrhea mentally.
Yeah, like an X-Men.
Like an X-Men. Yes, superpowers. Fecal superpower. We're called Fecal Man.
And that's where we just lost most of our listeners.
It's over. Anyway, so this trial, they looked at these patients for 6 months. Effexor worked well, so they continued it for another 6 months, and it worked even better. So they recommend essentially treating for 12 months. But at that point, let's reassess symptoms. Is everything going well? Just because things are going well doesn't mean we continue it indefinitely. We say, okay, well, let's look into tapering you off slowly and making you feel comfortable with that until we can get you off this medication and you can function without the medication and it doesn't affect your activities of daily living. Right?
Absolutely.
Yeah.
And tapering is huge.
Yeah.
Especially when we get back, talking about the SSRIs, SNRIs, tapering is essential unless you're dealing with like fluoxetine, which has a 9-day half-life. All the other ones you need to taper off because if you do not, and you can start getting discontinuation syndrome, which looks very much like depression, maybe some anxiety symptoms. So you don't know if the person's anxiety or depression is coming back. And so there's really no good way of differentiating them, at least unless you're, I guess, a true expert, maybe they can. But, it'd be something that you won't even want to, you may end up putting the patient back on meds for no reason. So titrate off. Yep. Don't just stop them.
And another thing I wanted to mention was, especially in these trials, so one way to assess how significant their anxiety is, do you really need to treat them? Or are they just, transiently anxious? So similar to depression, they have like the PHQ-9, they have the HAM-D score. They also have the HAM-A score for anxiety, so the Hamilton Anxiety Rating Scale. So it's basically a 14-point scale assessing pretty much exactly what you would think: anxious mood, tension, fears, how their sleep is, if they're having any GI, respiratory, or autonomic symptoms, any cardiovascular symptoms, stuff like that. There's also the GAD-7, which is, of course, the Generalized Anxiety Disorder 7 scale, which is a 7-point scale also assessing similar things. So if you're in the office and you're wondering, hey, is this patient going to need treatment? How significant is this? They're telling me about all these things that are going on in their life and they're anxious. Print off one of these scales, have them fill it out, take a look at it, and that might guide your decision making at that point.
Definitely want something to be able to quantify and measure the depression and not just going off of the patient's own interpretation, because that can vary depending on the person.
Right. Very
You're definitely
subjective. Which
going
I guess their answers to these scales are also very subjective. They could put 4s on all of them and, oh, well, here's your meds. But hopefully they're answering honestly, and you've got to assess that yourself as the clinician.
And I feel like it's a lot easier to answer a questionnaire, especially like, us guys, we don't like to admit when something, not right or we're not feeling well. So it's easier to tell the questionnaire instead of admitting it out loud. It's like less offensive.
I have a beard. I don't have a beard anymore.
Yeah,
so
you would have no problem.
No problem. I'll just talk about my feelings and everything.
Oh my God. I can't. Yeah, instantly.
Can't imagine.
You'd be talking about it with the nurse.
Right.
Get the doctor quick.
I need benzos.
They just give you some probably beard growth oils.
Right. Here's some biotin.
Yeah,
be careful about the cystic acne around your jawline.
Yes.
I think I actually told that story in a different podcast.
We did. We definitely did.
Yeah.
Because I ratted out my sister-in-law.
There's a couple people.
She was taking absorbent amounts of biotin for her hair to grow. And then she's like, I don't understand why I'm getting all this cystic acne. I was like, ooh, how much biotin are you taking?
Right.
Well, that's half the bottle gone already.
Yeah, man.
So, yeah. Watch your biotin, ladies.
So anything else with KR? I guess other than just, he's 59. I guess the Benadryl's not the biggest issue, but we could let him know that he might see some sleep benefit with the SSRI. Might be able to come off with that ZzzQuil.
Yeah, I would definitely tell him to stop the ZzzQuil and then start the SSRI first, and then work our way down the list, kind of going from there, and see how he does.
Sounds good to me.
And then just monitor that clopidogrel after that 12 months. Monitor and take it off. In case you missed last episode.
Yep.
And if you did miss last episode, you're making an enormous mistake.
Huge mistake.
So go
Worst
check that one out.
mistake of your life.
I was pretty excited because I was actually pretty nervous when we finished last week's episode, because since neither one of us are cardiologists. And
oh really?
Yeah, you know that?
Oh dang! I thought I was.
And
I'm telling people I am.
I have it on my LinkedIn profile. Cardiologist.
Cardiologist. Basically, honorary
Farm
cardiologist.
day.
Right.
And so I was a little nervous about it, but then Dr. Brian Gilbert, that you've heard on the Sepsis podcast and all that, he messaged us and was like, loved it. You guys did awesome. So I was pretty excited.
That guy knows what he's talking about.
Yeah, he's a smart guy.
Yeah.
Much smarter than I am.
Oh, yeah.
Brian, we're glad you listened, man. But, so it was a good episode. Good times. And, so we'll say goodbye to Mr. KR.
All right, KR.
Hopefully we'll see him next time with a different disease state.
Yeah.
And a whole different past medical history.
He can be our new case mascot.
Yeah.
We got enough of them now.
We
T-Rex
do.
RX, E equals MC, E equals RX squared, and Deadpool over there.
Yeah, Deadpool's new. For
He's
those
new.
of you who watch the video version of this, we have one of my students who just finished rotation with me. Christian, you saw him in a podcast a couple episodes ago. He got me a Deadpool little action figure looking guy with a gigantic head, and said he was going to start the tradition of buying trinkets for the podcast room that make no sense and have nothing to do with medicine that sit in the background.
I got nothing for his name.
You don't change Deadpool's name.
Okay.
Yeah, no. Under no circumstance.
Zero circumstance.
All right.
Okay.
Well, thanks you guys for listening once again and putting up with us. And please let us know if you have any questions, concerns. If you do enjoy the podcast, we would love for you to give us a rating on iTunes or Spotify or iHeartRadio or any of those that you listen to. And hit us up on Instagram, Facebook, Twitter, wherever you typically do your social media-ing. And we will see you next time. See ya.